So let's start with the brief introduction. So let's begin with today's session, for which I would like to invite Dr. Deepti Chaturvedi to take over.
Any problem in connecting?
No problem.
Okay, go ahead.
I was busy with the filters.
Okay. Go
Background
ahead.
filters. So let us start.
Okay.
Want me to start?
Yeah, he is already introduced.
Okay. So where is she? What's a good name? Jyoti. Who all are present? Shreya.
This is me, ma'am.
Pranab. Okay. Where are you? Where's the speaker?
Good evening, ma'am.
Where's the speaker? Speaker has not yet come.
Hello, am I audible, ma'am? I'm already there with the
We can
team
hear you. Who is that person? But we can hear, we can't see your picture.
Ma'am, I'm using my wife's laptop by
Okay.
by the name of
Achha,
Shreya Sardana.
so by the name of Shreya. Okay, I was
Yes, yes,
thinking
ma'am.
who. Okay.
Good evening, ma'am. Good
It
evening,
is
sir.
Bimlesh Thakur, speaker. Yeah, today I have called Dr. Gaurav Gupta also to give his expert opinion in the last, after your talk. If they all join, okay. Otherwise, we are all sufficient. We can do a bit. So let us start, I think so.
Yes.
Who is the host?
This clarinet people.
Yes, ma'am. Yes, ma'am.
Okay, go ahead with the
So what's your good name?
Ma'am, Mona Lisa, ma'am.
Mona Lisa. Oh,
Okay, every day they are changing new. Pranavesh Viswas. Okay, it's some new face. आपका ना थोड़ा सा नीचे जा रहा है मुंह, थोड़ा सा ऊपर अपने
ठीक है.
चेयर को ऊपर कर लीजिए.
ठीक. Go ahead. Start with the program.
Yeah, okay.
So, good evening, members.
एक
Warm
मिनट
greeting
आप
from.
रुकिए. We have a little introduction.
Okay, ma'am.
Yes, where are you? From the clarinet?
By the name of Shreya Sardana.
Yeah. No. Pranav Vishwas. Someone was hosting on the name of Pranav Vishwas. Where are you? Acha, Mona Lisa. Mona Lisa, you are even muted and your video is also off.
Yes, ma'am. Yes, ma'am. Yes, ma'am. Sure, ma'am.
Start with the program. Go ahead with the clarinet executive step on.
Yeah.
Hello, ma'am.
Okay.
Yeah, you can start. You know the series, no?
Yes,
What all
ma'am.
in
Yes,
order?
ma'am.
Yeah, you just put all the series in order and give the intro of the clarinet, and then a little prayer will do, and then we'll start.
Okay, ma'am. Okay, ma'am.
Okay. इनमें वॉल्यूम फुल कर रखी है ना सबने?
हाँ, सभी हैं.
Right.
I think she is a new person, so finding it difficult.
Now, as she'll start, they have
Good evening,
well-trained
one and
people.
all present here. I am Monalisa from Clarnet, the designated session assistant for the seamless experience. And Clarnet is India's most trusted and widely used digital platform with multiple enriching services exclusively for doctors. Clarnet is very proud to be a part as a digital partner for this event organized by Oncology Integrated Society. And the topic of today's session is recent concept on cancer gallbladder. Now I would like to inaugurate the session with a picture of lamplight.
Yeah, so all of us can join for a little prayer, which is actually an IMA prayer, but we who all know can recite with us. Yes, Doctor, please start the prayer.
Let us begin with the prayer. Sarve bhavantu sukhina.
Sukhina sarve
Niram.
santu niramaya sarve bhadrani pachantu ma kachit utpadbhave natvam kamaye rajyam na swargam na punarbhavam kamaye vipatthanam praninam arthanashnam. So may there be peace, good health prevailing in the universe, and may the wisdom of knowledge conquer all the diseases. May all become free of cancer like dreaded disease. With this little prayer and blessings of the Almighty, in the days of the Jagannath Yatra and of course Navratri also, we begin this gallbladder cancer management with the Oncology Integrated Society and Dr. Chaturvedi Cancer Hospital Private Limited and Research Institute. Good evening, everyone. It's a proud privilege and honor to keep on holding these webinar series, which are one of its kind, in which we involve all the oncosurgeons, medical oncologists, gynae oncologists, radiation oncologists, and the various multidisciplinaries oncologists. So as we know, cancer gallbladder was first detected in 1777. And after 200 years also, more than that, it is still the highly malignant disease with a very poor survival rates. So it is one of the most common biliary malignancy. It occurs in the 6th and 7th decade of one's life, and more common in women, 3 times more common. And it has highest incidence in the northern India and the southern Pakistan, North America, Native Americans who have immigrated from Latin America. And these cases have an overall survival rate of less than 5%. Median survival rate is of 6 months. So in the developed world, it used to occur, and it is occurring less, 1 to 23 per 100,000. And in the developing world like ours and the subcontinent of India, it is more prevalent. It is around 1 to 2%. That is per 100,000, and this is percent. So the reasons are still unknown, but 90% of them have a coincidence of porcelain gallbladder stones, stones with porcelain gallbladder. So now I'll request Dr. A.K. Chaturvedi, the chairperson, to take the chair, who is also the owner of Chaturvedi Cancer Hospital, past president UPARI, who has many theses to his credit, and who has many awards in national and international, and has been under training abroad also. Over to you, Dr. A.K. Chaturvedi. Kindly introduce the speaker.
Thank you, Dr. Deepti, and thank you, Clarnet. Today is very important topic regarding recent concept on management of carcinoma gallbladder. You know, it's very important malignancy, especially for this area, Eastern UP, and this malignancy is very common along the coastal margin and those who are residing along the bigger rivers. So it is very common in those areas with hot, humid climates. So today's speaker is Dr. Bimlesh Thakur. He is quite a learned person. A brief introduction about him. He has done his MBBS from Maulana Azad Medical College, did his internship and residency also from there. He got training in Pennsylvania, University of Pittsburgh Medical Center, clinical rotation, clinical care, medicine, cardiology, and transplant ICU. In 2010, then he did his residency in Lady Harding Medical College. Then he did general surgery, MS general surgery from there, and he worked as registrar in RML Lucknow. Then he shifted to Rama Medical College, consultant surgical oncologist in Rama Medical College, consultant surgical oncologist in KMC Cancer Institute, and at present he is working in Sir Gangaram Hospital, New Delhi, as the associate consultant surgical oncologist. He is expert in head and neck cancer, gastrointestinal, hepatobiliary, genitourinary, gynec, peritoneal surface malignancies, thoracic and lung cancer, breast cancer, cutaneous soft tissue and bone sarcomas, plastic reconstructions, open as well as laparoscopic oncological procedures, chemoport placement, surgical assessment and management of critical care. He has got many awards to his credit. He represented his college for the Torrent Young Scholar Award, second position in chess competition, so he's a good player. Presented free oral presentation in 24th National Conference of Indian Association of Surgical Gastroenterology 2014. Actively he was organizing conference titled Medicus Conventus in June 2017. He had gold medal in MCS surgical oncology, best outgoing student. He is quite a learned person. He has got many papers to his credit, so many publications. So I would like to listen from Dr. Bimlesh Thakur. He is MBBS, MS, MCS surgical oncology. So welcome, Dr. Bimlesh. You can go ahead with the presentation. Let us see the recent concept.
Thank you so much, sir, for the warm welcome. And warm greetings from New Delhi to sir and Dr. Deeptis. And thank you, Clarinet, for organizing this session. Let me share my screen and start.
Kindly allow.
Sir, I would like to ask Mona Lisa to stop sharing her screen so that I can begin sharing mine.
Share screen.
This one. Good evening, everyone. So today we'll be talking about a very important topic, carcinoma gallbladder. So we are right now sitting in the world capital of CA gallbladder, and with the highest incidence in India, which is 10 to 22 cases per 1 lakh. And it is highly endemic in Asia, Eastern Europe, South American countries, like particularly Chile, Bolivia, Ecuador, and Japan, particularly along the Gangetic belt. And its geographical variability correlates quite with the prevalence of cholelithiasis. So risk factors traditionally has been known to be gallstones. And However, the cholelithiasis, among all the patients with cholelithiasis, only 0.5 to 3% develop carcinoma gallbladder. But among all the carcinoma gallbladder patients, 90% of them we find cholelithiasis within them. Porcelain gallbladder has been known to be a classic risk factor. Traditionally, a risk of up to 22% have been reported, but recent reports report a risk of 7 to 11% only. Gallbladder polyps, they are also a risk factor for CA gallbladder. Larger polyps confer more risk, and polyp more than 1 centimeter is very particularly a high risk factor for development of carcinoma gallbladder and warrants a prophylactic cholecystectomy. Chronic infections like Salmonella typhi, carrier status, Helicobacter bilis infections, they also are implicated in carcinoma gallbladder genesis. Congenital biliary cyst, they increase the risk of biliary tract cancers, particularly cholangiocarcinoma, as well as gallbladder cancer. Abnormal pancreatico-biliary duct junction, it predisposes to reflux, biliary damage and inflammation. And particularly in this situation, prophylactic cholecystectomy is recommended. Medications like oral contraceptives, hormone replacement therapy, isoniazid are also risk factors. Carcinogen, smoking is a known carcinogen. Obesity and diabetes are also implicated as risk factors. So histologically, mostly they are adenocarcinomas, but squamous, adenosquamous, and small cell carcinomas have also been found, where squamous cell carcinoma tend to be of higher grade and have a worse survival. Morphologically, gallbladder cancer can be infiltrative, nodular, or papillary, or a combination of all these morphologies. Papillary carcinomas have a favorable prognosis, particularly. Carcinoma gallbladder can be suspected preoperatively or intraoperatively at the time of surgical exploration for cholecystectomy or other disease. Postoperatively, also gallbladder cancer can be found on histopathological report. And early invasive gallbladder carcinoma mostly are asymptomatic, but they present late because of symptoms. The most common of them is pain, followed by lack of appetite, nausea, and vomiting. Obstructive jaundice is a very important symptom in carcinoma gallbladder, which can result from direct invasion of biliary tree from the tumor or presence of lymph nodes in the hepatoduodenal ligament. Physical examination reveals a palpable gallbladder, jaundice, and ascites. And usually patient present with an ultrasound report suggestive of asymmetric gallbladder wall thickening and gallbladder mass or a mass infiltrating into the liver. However, dual phase CT scan with contrast or multiphasic MRI is recommended by NCCN and ESMO and should be done. Endoscopic USG can be used in equivocal cases, and however, chest CT is required for staging. But PET CT is the role of PET CT is not very confirmatory, and for unresectable and locally advanced carcinoma gallbladder, molecular testing is advised. These are the several genes which should be tested for comprehensively in locally advanced and unresectable carcinoma gallbladder, which typically indicates anti-RK gene fusion or HER2 new overexpression, MSI high, tumor mutation burden, BRAF mutation, and RET gene fusion. Elevated serum bilirubin may be found in blood test, or ALP can be raised. Serum tumor markers CEA and CA 19.9 are not diagnostic, but if they are elevated, they can be used as serial markers. And anatomy of gallbladder we are quite familiar with. And the segmental liver anatomy, we should be aware of it. Most important thing is that we should be aware of the anatomical variations while dealing with the gallbladder cancer, where the cystic duct may have a longer course, a smaller course, or may have a swerving course. So, lymph node dissection during the surgical treatment of carcinoma gallbladder involves cystic duct, common bile duct, hepatic artery, and portal vein lymph nodes, which are called locoregional as per 8th edition of AJCC. And tumor involvement of para-aortic, paracaval, and superior mesenteric artery celiac lymph nodes is considered distant metastasis. So during curative surgery, lymphadenectomy is not performed beyond the porta hepatis and hepatoduodenal ligament. So TNM staging we are quite familiar with. The recent AJCC guidelines have changed the T2 classification into T2A and T2B because the prognosis of the tumor varies whether the tumor is present on the hepatic side or the peritoneal side of the gallbladder. And the recent AJCC classification has also reclassified N1 and N2 into presence of 1 or 3 lymph nodes as N1 as compared to 4 or more regional lymph nodes as N2, as compared to the previous non-regional lymph node metastasis as classified as N2. Carcinoma gallbladder can be diagnosed before surgery when with an abdominal CT with a dual phase contrast is used to rule out extra-regional lymph nodes, vascular invasion, liver spread, or peritoneal implants. The CT also helps in assessment of the hepatic arteries, major portal vein, and adjacent organ involvement. Abdominal MRI can also be used particularly to evaluate the liver parenchyma and bile duct anatomy in cases presenting with jaundice. Chest CT with or without contrast is required for staging to rule out distant metastasis, and role of PET scan is controversial and it should not be routinely used. Staging laparoscopy is recommended prior to laparotomy for all suspected or proven gallbladder cancers more than PT1B. Absolute contraindications during laparoscopy involve liver metastasis, peritoneal metastasis, malignant ascites, involvement of non-regional lymph nodes, extensive involvement of hepatoduodenal ligament by tumor or large bulky lymph node, encasement of major vessels, common hepatic artery or main portal vein. Preoperative jaundice is a relative contraindication to was previously considered a relative contraindication to radical resection of fundus-based gallbladder cancer, but surgery can be planned in appropriate circumstances. However, for perihilar type gallbladder cancer, those presenting with obstructive jaundice, it is usually surgically not feasible. So definitive resection involves en bloc resection of the gallbladder along with a 2 centimeter margin of underlying liver bed, which can be either non-anatomic resection or anatomic resection of segments 4B and 5, along with the lymphadenectomy of portal and hepatoduodenal ligaments. Extrahepatic bile duct resection is not routinely done, but for achieving margin-free status, it should be considered. For locally advanced tumors, en bloc resection of adjacent organs like duodenum, colon, or pancreas may be required and should be considered. This diagram briefly shows the extent of the liver resection done during non-anatomical resection and the resection required for anatomical resection. So, gallbladder cancer incidentally found on pathological review. Usually, those with T1A negative margins, laparoscopic cholecystectomy, a simple cholecystectomy is sufficient. However, if the cystic duct node was found to be positive, it should be staged with a multiphasic CT scan along with staging laparoscopy, and consideration should be given to neoadjuvant chemotherapy in these circumstances, followed by surgical definitive resection. However, for tumors larger than more than T1B or T1A with positive margins, staging evaluation should be done with the CT scan or MRI and staging laparoscopy. And if found resectable, definitive resection should be done. If it is found to be unresectable, then molecular testing and systemic therapy should be considered. If gallbladder cancer is diagnosed on imaging investigations and on clinical findings preoperatively, it should be staged with abdominal CT or MRI, and chest CT should be done with or without contrast to rule out lung metastasis, and staging laparoscopy should be considered to rule out any absolute contraindications to resection. And if it is found to be surgically curable, extended cholecystectomy with en bloc resection of liver bed and portal and hepatoduodenal ligament lymphadenectomy should be done. Cystic duct margin should be assessed by Frose's section, and if required, extrahepatic bile duct resection should be considered for positive cystic duct margin. So this slide summarizes the same thing. T1B, T2, or T3 gallbladder cancer after incidental gallbladder cancer detection, surgical resection should be done. However, for T1A, N0, M0, simple cholecystectomy is sufficient. Bile duct should not be routinely resected, but if gross tumor extends into the CBD or the cystic duct margin shows tumor involvement, bile duct resection should be considered. Otherwise, routine resection of bile duct is not required for lymph node dissection purposes. For all gallbladder cancers more than T1A, lymph node dissection should be done, which includes lymph nodes in the porta hepatis and along the hepatoduodenal ligament. A minimum of 6 lymph nodes should be removed for proper staging, and involvement of lymph nodes beyond the hepatoduodenal ligament is considered distant metastasis, and the surgery should be abandoned if it is found intraoperatively. Following surgical resection, adjuvant treatment should be planned. The prognosis of carcinoma gallbladder is among the worst of the cancers. The 5-year overall survival, even after successful resection, varies from 5 to 32% only, and with a recurrence rate of 35 to 67%. And it has been found that 2/3 of the recurrences present within 12 months, rest present within 24 months. And that introduces the concept of conditional survival. Those who survive the initial 12 months or 24 months, they tend to survive longer as compared to other patients. So the prognostic factors include T-stage, lymph node metastasis, status of surgical margins, tumor grade, and lymphovascular and perineal invasion. So adjuvant therapy is indicated in all patients with resected gallbladder cancer except node-negative T1A tumor. So as per BILCAP trial, 6 months of post-operative chemotherapy alone with capecitabine, 1250 milligram per meter square of total dose given twice daily is considered as per the BILCAP trial for all the resected carcinoma gallbladder patients. 5-FU based chemoradiotherapy with 4 months of systemic chemotherapy is also acceptable, particularly for patients with margin positive disease and advanced cancers. As per the SWOG 809 protocol, capecitabine monotherapy or capecitabine with gemcitabine can be used along with radiation therapy. So the BILCAP trial was a large phase 3 trial in which recruited 447 patients of completely resected cholangiocarcinoma or muscle invasive gallbladder cancer. Gallbladder cancer comprised 18%. They were randomly assigned to 8 cycles of capecitabine or placebo. And this trial found median overall survival and recurrence-free survival to be increased with the capecitabine chemotherapy. However, the benefit was not found in intention to treat analysis, but this trial finds the basis of adjuvant chemotherapy treatment for carcinoma gallbladder. However, there are no trial as such for comparing capecitabine with the gemcitabine cisplatin chemotherapy. Actica-1 trial is ongoing and will bring results. Utility of gemcitabine-based chemotherapy combination regimens is uncertain still. A Japanese trial of mitomycin plus infusional 5-FU followed by prolonged oral administration of 5-FU until terminal progression was also done, which also showed a significant improvement in survival rate, which was around 26%. There were several negative trials also. PRODICT 12 trial compared gemcitabine with oxaliplatin, and Indian trial with gemcitabine cisplatin. Retrospective trials were done where SEER Medicare database of 1137 patients showed that chemoradiotherapy outperformed chemotherapy alone. Similarly, NCDB database of 5,000 patients also showed significant improvement in the survival rate with any form of adjuvant therapy, chemotherapy and chemoradiotherapy. However, radiation therapy alone was not associated with clinical benefit. The SWOG 809 trial was a trial of chemoradiotherapy. It was a feasibility study where a single arm trial of 105 patients with hilar or distal cholangiocarcinoma or gallbladder cancer were recruited, and they were given gemcitabine, capecitabine chemotherapy followed by concurrent capecitabine and radiotherapy to the tumor bed as well as regional lymph nodes. And the 2-year survival rate was found to be 65%, which was quite significant. And ASCO considers this regimen for particularly for those patients with margin positive resection. There were 2 retrospective studies also which demonstrated benefit of chemoradiation therapy, and NCDB database analysis, as we have discussed previously, also showed benefit of chemoradiation therapy. This slide basically shows the randomized trials for adjuvant therapy in gallbladder cancer. ABC02 was actually a trial for advanced biliary cancer rather than adjuvant, but the results have been extrapolated, where gemcitabine cisplatin chemotherapy was found to be more beneficial than gemcitabine alone. PRODICT 12 and ACCORD 18 trial was negative trial, where while BILCAP trial established capecitabine as the standard adjuvant chemotherapy treatment for resected carcinoma gallbladder. BCAT trial was also for biliary tract tumors, which showed benefit of gemcitabine over surgery alone. SWOG 809, as we have discussed, showed benefit of chemoradiation therapy and feasibility of chemoradiotherapy as an adjuvant treatment for resected carcinoma gallbladder. Advanced unresectable gallbladder cancer present a particular challenge to us because most of the patients present with under this category only. Obstructive jaundice is usually the presenting feature in 30 to 60% of the patients, and this requires stenting via either an endoscopic or percutaneous approach. Biliary or intestinal bypass can also be considered, but usually is considered late. Initially, an endoscopic attempt at drainage is usually preferred in most of the centers. A drainage of as little as 30% of the liver is sufficient to palliate the symptoms. So, bile duct obstruction can be high or low, depending on whether it involves the confluence or not, and bismuth correlate classification classifies the bile duct obstruction. So the point to note is that low bile duct obstruction should be managed with the endoscopic means, whereas high bile duct obstruction, as typically found in carcinoma gallbladder, should be treated better with the percutaneous transhepatic approach. So this similar scenario was evaluated in a trial of 54 patients with gallbladder cancer and type 2 or type 3 obstruction, biliary obstruction, where successful drainage was more often achieved with percutaneous drainage rather than endoscopic approach. And cholangitis was also more common with endoscopic stenting. However, rate of stent occlusion and median survival were not significantly different. So this picture shows a type 3 obstructive jaundice, where an endoscopic stenting has been done into the right posterior segment. This shows that this also causes near complete occlusion of the right anterior division as well as the left hepatic duct. So this kind of obstruction should be better dealt with the percutaneous transhepatic approach rather than an endoscopic approach. Chemoradiation has been compared versus radiation therapy for locally advanced non-metastatic disease. Tumor control is rarely achieved with radiation therapy alone. However, infusional fluorouracil delivered during a course of EBRT is the most commonly used approach, and NCCN also suggests the same. ESMO guidelines suggest a systemic chemotherapy, and RT can be considered after first-line chemotherapy. Palliative systemic chemotherapy should be considered, which shows an objective response rates ranging from 10 to 60%. The only randomized controlled trial showed the chemotherapy was better at overall survival as compared to the best supportive care. The first-line chemotherapy options are gemcitabine with cisplatin, as per ABC-02 trial, which showed increased median overall survival with this chemotherapy combination. Topaz 1 trial showed benefit of gemcitabine cisplatin with PD-L1 antagonist durvalumab. This trial enrolled 685 patients, which showed a median OS benefit of 12.8 versus 11.5 months, and objective response rates of 26 versus 18%. This also showed significantly improved overall survival and progression-free survival. So based on this trial, NCCN recommends this as the first-line systemic treatment option for unresectable or metastatic biliary tract cancers. Gemcitabine plus capecitabine or gemcitabine with S1 can also be considered as first-line chemotherapy options. Gemcitabine along with oxaliplatin, cisplatin or carboplatin should also be considered. These are the preferred regimens and subsequent regimens for the first-line treatment of unresectable metastatic carcinoma gallbladder. The durvalumab with gemcitabine and cisplatin has been considered as category 1 regimen. Gemcitabine, cisplatin, FOLFOX, capecitabine, oxaliplatin, and other regimens are also recommended. Patients with biliary obstruction present a peculiar scenario. Those with persistent hyperbilirubinemia, despite stenting, a non-gemcitabine based regimen chemotherapy can be considered. Leucovorin modulated 5-FU with cisplatin shows an improvement in median survival. Epirubicin, cyclophosphamide, and 5-FU combination is also an acceptable alternative with lower toxicities. 5-FU with oxaliplatin combination can be considered also in this circumstance. Those with borderline performance status should be dealt with single agent gemcitabine, capecitabine, or gemcitabine cisplatin combination. Second line chemotherapy options include FOLFOX as per ABC06 trial, which should improve overall survival, and immune checkpoint inhibitors should be considered, where those with deficient MMR or MSI high or high tumor mutation burden can be offered pembrolizumab. Those expressing PDL1 can be dealt with nivolumab, and nivolumab combination with ipilimumab can be considered for others based on the open label CA 209 trial. 5-FU alone can be considered. Irinotecan, liposomal irinotecan with leucovorin FU, as per NIFTY trial, can be considered. Capox is an acceptable alternative. Gemcitabine and capecitabine combination can also be used. All patients with metastatic or advanced carcinoma gallbladder should go somatic tumoral genomic testing to assess for the molecularly targeted therapies. MSK impact and F1 ODX is an example. So these are the specific gene mutations that can be looked for in comprehensive gene panel. It should be noted that HER2 new overexpression and anti-RK fusion and MSI is quite frequently found in gallbladder cancer. A brief word about neoadjuvant therapy. Neoadjuvant therapy is considered to be largely to rule out rapid progression and avoid futile surgery in carcinoma gallbladder. Hakim and colleagues performed a systematic review where they assessed the feasibility of neoadjuvant chemotherapy, where they found that 1/3 of the patient had progressive disease despite neoadjuvant therapy, and 2/3 demonstrated clinical benefit. Half of the patients were considered suitable for surgical resection, and resectability rate was found to be around 13 to 66%. The overall R0 resection rate was 35.4. Several randomized controlled trials are awaited in this for neoadjuvant chemotherapy. Neoadjuvant chemotherapy should be considered for incidental carcinoma gallbladder with a positive cystic duct node. And it is also a category 2B indication for obstructive jaundice after biliary drainage. A systematic review has shown that approximately 1/3 of the patients had achieved an R0 resection with the use of neoadjuvant chemotherapy or chemoradiotherapy in this particular setting. So the preferred regimens for neoadjuvant chemotherapy is FOLFOX. However, capecitabine, oxaliplatin, and gemcitabine cisplatin can also be considered. Durvalumab along with gemcitabine and cisplatin can also be considered. Following successful treatment of carcinoma gallbladder, NCCN recommends strict surveillance every 3 to 6 months for the first 2 years, and then every 6 to 12 months for the later 5 years, or as clinically indicated. An imaging of chest, abdomen, and pelvis should be done during these visits. So to summarize, carcinoma gallbladder is a highly endemic disease of India, and high index of suspicion should be considered during surgery for gallbladder, and proper planning for the carcinoma gallbladder treatment should be done, and adjuvant and neoadjuvant chemotherapy are helpful in appropriate circumstances. And a lot of patients with carcinoma gallbladder will present for palliative chemotherapy rather than curative therapy for us. So with this, I would like to conclude my presentation, and would like to invite any questions, which I'll be happy to
Yes,
ask.
Mona Lisa. Hello, clarinet people. Clarinet people. I think so. There are no questions. But what I would like to ask you is, like you have said, we do so many mutations. Like, how does it change the treatment part
Ma'am,
when there are so many regimes?
ma'am,
Is there
those
any particular regime for a particular mutation?
Ma'am, the first line systemic chemotherapy, systemic therapy has been defined, but those who fail the first line systemic therapy, they would require a comprehensive gene panel test so that an actionable mutation can be found, and significant results can be found with that.
Dr. Gaurav Gupta is also with us, I think so. I had invited him as a special guest. Yes, Dr. Gaurav Gupta, are you there?
Yeah, madam.
Yeah,
Hello,
he is
sir.
medical
Greetings from
oncologist. Yes, give a brief. Tell us something about yourself.
So I'm a medical oncologist.
Your video is off.
Okay. Just hold on.
Mm.
Yes, Dr. Gaurav.
Hello, sir.
How are you?
Hello
Yes,
to
sir.
see you.
You
Nice to
are-
see
Hello, sir.
I am a medical oncologist in Lucknow. I got my DM from
They had
Tata.
come to IMA. They had all come. Medanta Lucknow में है ना आप डॉक्टर?
नहीं मैम, मेरा अपना सेंटर है फेमस oncologist.
Okay.
So basically, second line and beyond, you can use NGS, but the problem is accessibility to the drugs. There is a drug for IDH mutation. There are drugs for NTRK mutation, but
Does it improve the overall survival?
so we don't have anything in the second line. Okay, so these are all targeted based drugs. Like for MSI, it is proven that this immunotherapy works. Similarly, for NTRK, we have a basket trial which proves that this drug works in patients who have this mutation. So you won't get any phase 3 data for this, but that is the best data we have at present.
Which may be effective, as you say.
Even for HER2, there is some data.
But phase 3 trials are yet to come.
Yeah, but then there is no approved phase 3 therapy in second line in gallbladder cancer as such.
In fact, there are very few drugs available for the
Yeah.
treatment. And Dr. Bimles, I would like to ask one thing. As you
Yes,
see,
sir.
of the chronic cholecystitis cases, we find dysplasia in those cases sometimes. And most of the cases, they turn up after 2-3 months that they were the malignant cases. So is there any, I would like to ask from the pathologist if they are available here, or if you have any answer. Are you able to listen to me?
Yes, sir.
Okay. So from dysplasia, when it has gone to frank malignancy, if you, after surgery, if you are able to find out when it has gone to malignancy, is there any stain or anything like that? Because most of the cases, most of the pathologists, they fail to diagnose carcinoma gallbladder. They just report chronic cholecystitis or dysplasia at the maximum. So that is very important to pick up the cases in early stages. Simply, they do.
Dr. Biblesh will say that if there is dysplasia, better remove gallbladder.
That is after removing.
Oh,
That's the problem. So how
still
do
it
we?
comes back. After removing, how will it come
Yeah.
back?
Well, they report as chronic cholecystitis, and they turn out to be malignant.
Yeah,
So
we
this
also
something. This is very gray area for diagnosing the carcinoma gallbladder, and that's why the patient come in late stage. After 3 months, they come with mets in liver. So that is one thing. And second thing is preoperatively when you do CT scan, dual phase CT scan, as you said, if you are able to diagnose, then how will you proceed? Proceed as definitive. You said you do laparoscopic, diagnostic laparoscopy, find out the extent. So should we straight away go for surgery after dual CT? And because there is no means to diagnose as this type of cases as carcinomas. So straight away, do we plan for definitive surgery, radical cholecystectomy with lymphadenectomy? Or should we go ahead?
So diagnostic laparoscopy is usually the first step of any curative surgery for carcinoma gallbladder, and it should be done as a routine part of all the carcinoma gallbladder surgeries. So during the diagnostic laparoscopy, we have to rule out all the absolute contraindications to surgery, like presence of peritoneal implants, omental deposits. We should assess the presence of non-regional lymph nodes, as well as distant metastasis in the abdomen. And if we find we are satisfied with that, with the diagnostic laparoscopy, we should proceed with the open surgery and do an extended cholecystectomy and lymphadenectomy.
Smaller cities is possible in bigger hospitals, and a
Yes.
smaller, once you do laparoscopy, the surgery is over. They don't turn up.
Yeah.
They don't
So
go for
only we need the advances, na? That's why
Yeah.
there is a decrease in the developed countries, and still it is increasing in the developing countries like ours and Pakistan, because gallbladder operation is done by every surgeon. It should be done either by an oncosurgeon when in suspicion, or it should be properly done by खोला तो देखा आपने, so lymph nodes also should be removed, as correctly said by Dr. Bimlesh, that omental deposits देखो, lymph nodes देखो, gallbladder resection of some portion of the liver, all that should be done, like it should be done radical cholecystectomy, not just the cholecystectomy alone. And I think so when you find dysplasia, like you said, there's a role of this
frozen section.
checking the HER2 and BRAF mutation and all these things. So the सबको combine करके then we can think of what कि वो गलत diagnosis है, and if there is a genetic predisposition, so straight away add capoda or capecitabine, I think so, is that only, no? Capoda, that should be added.
Yes, sir.
What do you say? You
It is
both
not
decide.
We have to do a genetic study that is important. And since this is a very dreaded disease, once it is diagnosed, it's very difficult to control. Very, very difficult. And it is such a notorious disease, even lesion, they get metastasized in due course of time, even after surgery. So I don't know how to cope up with this type of things. Anyway, very nice presentation. And regarding, one more thing, regarding chemotherapy, whether it is acute or for palliative cases, I think after treatment, we should follow the patient for at least 6 to 12 months and give them maintenance chemotherapy simply with capecitabine. That will work wonder. That's
Very
important.
rightly. Because I've
Because-
seen you doing capoda. Yeah.
Yeah.
That only improves the result. So with treatment, 2 years, and without treatment, 6 months. What do you say, Dr. Bimlesh?
Yes, rightly said, ma'am. With treatment also, the prognosis is not as good as we have achieved in other cancers.
In other type of.
Yeah. So regarding the prudent approach for cholecystectomy at not so big centers, I think best is to document the findings during the laparoscopic cholecystectomy. If they find any suspicious things in the laparoscopic diagnostic laparoscopy, and if possible, if there are no other contraindications for surgery and the lesion is not extending into the liver, simple cholecystectomy can be done. And if a mass has been found, then it can be abandoned if expertise is not available there. So that should
Thank
be.
you, Dr. Vimlesh, and thank you, Dr. Gaurav Gupta. Dr. Gaurav Gupta has mentioned that he has to leave. So thank you, Dr. Gaurav Gupta, for emergency coming, visiting all of us. Are you there or are you gone?
No, he is left. He just now left.
Acha, he has left. Anyway, I just asked him to come like a guest artist in between
Yes,
and
he
give
left.
his opinion and view, and he was so sporting to join us at the last moment, last hour. Anyway, do you have any video regarding how you do bile drainage? Clarinet, I just requested you. You didn't receive any video. Okay, that would be really good. Hmm. You could have from YouTube you can download and see anyway. That would be good for our audience. It's okay. Next time we can add to any other liver cancer and all that. We can add the videos. So, thank you all for joining and actively participating and giving a light to the new dimension to the treatment of cancer gallbladder, which is still very notorious and the worst of all the cancers. But still, we shouldn't lose hope. We should keep striving. We should keep fighting. We should not fear it. And at least we do something good when the patient says, yes, you gave me life so that I could accomplish certain tasks. So that is the end of giving a big extension to those patients who has to die, who has to face death in a moment. That is what we doctors do, and that is what we ask God for, blessing us to show us more light and more knowledge and to rise more to help all our patients, to guide them towards good and give them a good quality of life. So, with these words, I would ask Dr. Chaturvedi to share his experiences regarding gallbladder cancer. What are
Okay.
your experiences?
We are already discussing regarding this. It's a worst type of cancer. And with the
Hmm.
neoadjuvant chemotherapy followed by surgery in early cases, then again maintenance chemotherapy, we can improve the survival. And the main crux is we have to diagnose in early stage. That is more important. So most of the surgeons, they should take a note whenever they find chronic cholecystitis cases. Keep in mind the malignancy part also, especially single large stone more than 3 mm. That is very, very suspicious of malignancy. There are more chances of developing malignancy in single stone rather than multiple stones, especially cholesterol stones. So these are all few things which we can express. But anyway, Dr. Vimlesh, very nice presentation. Thank you very much.
Thank you, sir. Thank you, ma'am. It was a great pleasure and honor for me.
Thank you. Thank you so much. Over to Dr. Deepthi and the clarinet. Clarinet people. Yeah.
Thank you for extending us the opportunity to host the session today, and I hope you had a great experience. With your due permissions, I am closing the session today and looking forward to hosting you again, sir.
Okay.
Okay, thank you all.
Thank you. Thank
Thank
you,
you.
ma'am.
Thank you
Thank
for
you,
your
ma'am. Thank
technical
you, Clarinet.
support, ClearNet people. Thank you. Thank you, Dr. Vimlesh.
Night,
Thank you,
Okay.
ma'am.
everyone.
Thank
Thank
you
you,
all
sir.
the participants for being lovely audience and registering in time. Thanks a lot.
Thank you, ma'am.